Thank you, Kavita. Good morning, all. Today is the fourth part of the fetal echo session and series. So the last session we had discussed about the fast heart rate, fetal tachycardias, and irregular heart rate. So today we will look into the slow heart rate in fetus. Overall, bradycardia is much less commoner. The most common is irregular rhythm, including ectopics, and it constitutes only 5% of the total abnormal rhythm which is found in the fetus. So today what we will see is the definition. How do you define fetal brady, the causes and an approach and management in short. The basics of electrical activity, we had taken it last time, so I will just run through it. Understanding that by 16 weeks, we have a fully functioning electrical conduction system, and based on the systole and the diastole, we understand that the part of systole which can be understood in fetal life is the ejection period, and in diastole we can have an understanding about the rapid inflow and the atrial systole. And how do we do this is based on the M mode and Dopplers, but 2D also plays a very important role. So as soon as you start your fetal echo, just the basic axial view will tell you whether you have any abnormal rhythm or not. Usually you will have an idea when you start. However, after that, you will need to take help of M mode and Dopplers. Now, in general, we understood this last time that on M mode, we cannot have the understanding of the PR interval in a particular, and the accuracy of determination of PR interval is not that much as what we have it on Doppler. The M mode also, you can see the atrial and the ventricular wall moving, so you can document your atrial and ventricular activities. However, the position of the fetus is important, where you need to have a cut of an atrial and ventricular activity in the same view. When there is high drops, then it's difficult to get that movement. On Doppler, you can take use of LV inflow outflow and aorta SVC Doppler commonly, but you can take pulmonary artery, pulmonary vein, hepatic vein, PFO, pulmonary artery, any combination of an arterial and venous activity. So as you can see here, this is the M mode, the atrial and ventricular activity, every atrial activity followed by ventricular activity. And here, this is the LV inflow outflow, where below the baseline you have mitral inflow and above is the aortic outflow. And here you can see the SVC in the third image, which is below the baseline, which includes the S and the D wave. And then after a short pause where the A wave may not be well visualized, you have the ventricular activity above the baseline. So now with this understanding, let's see what gives us a good understanding about systole is the Doppler of this aortic valve or the pulmonary valve. The E wave in the AV valves, which is the initial part of the diastole, is the rapid inflow, and the terminal part, which is the A wave, gives an understanding about the atrial systole. You can also have this A wave seen in the veins like SVC, IVC, pulmonary veins, or ductus venosus. So finally, we understand that M mode and Dopplers both form the cornerstone for diagnosis. However, Dopplers are important for understanding the duration of PR interval. This duration of PR interval and RP interval is important for tachyarrhythmias, which we saw in the last session. But for bradyarrhythmias, also the PR interval is important. And how do we calculate the PR interval? This is also sort of a revision from the last session. So this is what is LV inflow and outflow. And you can see here that the A wave begins here. So the beginning of A wave and beginning of V wave in the LV inflow outflow view makes the PR interval. So this duration makes the PR interval. And in the SVC aorta Doppler, similarly, beginning of the A to beginning of the V here. So this is what you can see here, the S and the D, and then the end of the D and the beginning of the V. This is what is going to give us the PR interval. So with this understanding, we'll try to understand a little about bradyarrhythmias. We know that a normal sequence of electrical and mechanical activities, there is a 1:1 relationship. You need to have a regular AA, a regular VV, and AV coordination. So these three things are important, and we use these three things to differentiate different types of bradyarrhythmias also. So now fetal brady, what defines? So the cutoff usually, like in tachy, we understood that usually anything more than 180 is fetal tachy, but 160 to 180 is a gray zone. Similarly, you have a little understanding here on brady side also. So a heart rate which is less than 110 beats per minute, which is lasting for at least 10 minutes, is a fetal brady. Now remember that all of you would have seen whenever you put the probe and a little amount of pressure could cause transient bradycardia, and these episodes usually last for only 3 to 4 seconds. So understand that this sustenance is important. Any brady more than 10 minutes of rates less than 110 should be considered abnormal. Now, this in general, we know that the baseline heart rate will reduce as the advancing gestational age. So as the gestation proceeds, the heart rate, which is baseline, will start reducing. So you have something which is called gestational age specific centile charts for monitoring fetuses at risk, especially for families with long QT syndrome, because for them, a little variation here or there might make a lot of difference. But in general, remember that in second trimester, less than 130 beats per minute, and by term, less than 110 beats per minute is considered to be less than fifth centile. So in third trimester, any heart rate less than 110 beats per minute is abnormal, and this is what is fetal bradycardia. But remember that rates between 100 and 110 also cannot be considered to be completely acceptable anytime in gestation. So now what are the causes of fetal bradycardia? Now fetal bradycardia, you can have an issue at A level, or you can have an issue at the conduction from A to V. So let's see. First is you can have a problem with the sinus node. So you can have sinus bradycardia, or it is a low atrial bradycardia. The second possibility is atrial ectopics. Because of some reason we have automaticity and an ectopic atrial beat which is not conducted, you will have the ventricular rate reducing. So this is second cause, and we saw atrial ectopics in detail, whether they were blocked or could be transmitted. Both varieties we understood last time. But usually when it is brady, it is blocked atrial ectopics, because as we understand, the ventricular rate is going to be affected only when the ectopic beat is not conducted through the AV node. And the third reason could be we have a block at the AV node. Now here, the first and the third part we will be seeing in detail, because these two sections we haven't discussed last time. The atrial ectopics we have discussed at length, so we'll just run through with an understanding of a very important differential diagnosis which we will see. So the first thing is sinus bradycardia. Now, how do I know that the child has sinus brady and not, for example, an AV block and or an ectopic? So the most important is here that you have AV coordination. AA is going to be regular and VV is going to be regular. Now, as we saw in sinus tachy, in sinus brady also, reactivity is present. You don't have consistently the same heartbeat persisting. You have some amount of variation which is seen. So reactivity is present in sinus bradycardia. Sometimes you might find a reason in the mother, like mother might be on medications. So this is a situation where it's very important to run through the history in the mother and also the family history. So rule out any collagen disorders in the mother, any family history of, for example, prolonged QTC, any maternal medications or history of fever, which could point towards a possibility of myocarditis, any drugs like any psychiatric medications, sedatives, beta blockers taken by the mother, and also a structural understanding of the baby. Sometimes you might have an IVC interruption or a PAPVC like a picture, which could point towards left-sided isomerism. Then you know that this brady could be a part and a parcel of the whole picture there. Whenever you are confused whether is it a sinus brady or is it coming from a focus which is a little below the sinus node, which is considered to be a low atrial focus, both of which can look like sinus brady. So in that situation, your PR interval and looking at charts for PR interval could help. A shorter PR interval could favor more in terms of a low atrial rhythm. Now, whenever you have these rates of 100 to 110, 40% of these babies finally turn out to have sinus brady with long QT after birth. Long QT is a situation we cannot diagnose for sure during pregnancy. So there are situations where you have to be a little more alert for suspecting a long QT. Sinus brady will look like this on 2D. It's going to be almost closer to normal heart rate till you measure and you realize that your heart rate is 100 beats per minute and you have atrioventricular, atrioventricular, atrioventricular coordination. Now, sinus brady also sometimes could be mixed with a partial AV block in terms of long QT. So your rhythm could be changing from an ectopic to 2:1 to brady to even ventricular ectopics. So in that situation, you have to be careful. What you can do is just a close observation after a family history is ruled out. Maternal levels of potassium and magnesium would be important. Give the list of prolonged QTC drugs to be avoided to the mother and explain to them that your further evaluation will have to wait till the baby gets delivered. A neonatal ECG and sometimes a Holter could help us out at that point in time. So the learning lesson is any heart rate which is closer to 110 could be sinus brady, could be a prolonged QT after ruling out secondary causes. A follow-up observation during pregnancy is necessary with some evaluation after birth. Now the second was atrial ectopics, and as we know, sometimes the atrial ectopics are conducted and sometimes they are not conducted. Atrial ectopics in general constitute a significant amount, 80 to 90% of abnormal rhythm, but 30% amongst the fetal bradies. And the most important thing here is to differentiate 2:1 EV block from atrial ectopics. For example, you can see here, this is a sinus A beat to V beat, and this is an ectopic atrial beat, which is not conducted. So you have a pause and then you have a sinus beat. So this is basically atrial bigeminy, which is blocked. So every second beat is blocked. So this also will look very similar to 2:1 AV block, as you can see in the lower figure. You have an AV and then AN blocked, AV and AN blocked. So now what is the typical difference between the two? In the first situation, your AA interval is changing. And in the second situation, the AA interval is not changing. So this is the way to diagnose in fetal life. If your AA interval is changing, you know that it's an ectopic beat where alternate beats are ectopics and the ectopic beats are not conducted. Whereas if it's 2:1 AV block, my AA interval is going to be regular, my VV interval is also going to be regular, but my AV association is not going to be there every beat. So this is something which we did not understand last time. So I thought this is important. And the rest of the things related to atrial ectopics, I think we have understood. 1 in 200 chances of having an ectopic SVT. And what is needed is once in 4 weeks monitoring in fetal echo, whereas in between, whenever there is an OBGYN visit, the gynecologist can keep a check on the heart rate to just rule out a possibility of SVT happening. And most of the times, these ectopic beats would revert back to sinus rhythm. The possibility of a congenital structural heart disease is extremely rare. Now, with this understanding, we will go to the third category of cause of bradycardia, which is atrioventricular block. Now, you can see here in this figure, this is how it will look. Compared to the sinus brady, you can see here a little different. One is that the rate is quite on the lesser side. So it is very obvious. As soon as you put your probe, you will realize that, yes, the rate is not okay and I need to do a little work on the rhythm side. But more important than that, you can appreciate the movement of the atrial wall. even before you put an M mode, you can see here the movement of the atrial wall is much more compared to the ventricular wall movement. And this movement is very well seen near the appendage area. Always remember, when you want to do an M mode also, if you get a cut closer to the appendage, it will be easy. Either of the appendages, right or left, then you will appreciate the atrial wall movements much beautifully. Now, considering atrioventricular block, we have to have this very, very clear. The highest risk is between 16 to 24 weeks. Now, this duration is important, especially if the mother is antibody positive, mother also already knows that she is positive, and then we are monitoring a pregnancy, or if the first baby is having a heart block, after which the mother was evaluated and the mother is positive, the second pregnancy monitoring is going to be done very judiciously, where there you need to know that the peak period during which the possibility of developing AV block is between 16 to 24 weeks. Some people would say that after 26 weeks, it's less likely, and usually the monitoring after 30 weeks is not needed. The possibility of AV block can happen with maternal antibodies, as we discussed, but it can also happen in isolation or along with the structural heart disease. The first and the second possibility is much less compared to the third. Now, if it is happening with a congenital heart block, structural heart disease, then what are the heart diseases you would want to rule out? The most common would be atrioventricular septal defect. The second would be corrected transposition or left-sided isomerism. And this is where the importance of finding out if there is IVC interruption. So structural evaluation, you should always make sure that you see the IVC is not interrupted, and you see your left atrium like pulled ears, right-sided veins and left-sided veins both entering the left atrium. And your situs from the actual view before you start, that the liver is not midline, and IVC and aorta are to the either side of the midline. If they're on one side of the midline, again, it can be a pointer towards left-sided isomerism. Atrioventricular septal defect is easy to pick up. Corrected transposition grade arteries in absence of a defect inside. To pick it up, you need to be going very systematically for segmental analysis. So this is a situation where you would have to understand what is right and left before you start, so that you can understand the atrioventricular discordance existence. Now, remember, in general, when you have a structural heart disease, the mortality is very high. Mortality in fetal life is also very high. It is said that if you have an AVSD with a complete heart block in fetal life itself, 80 to 90% of the fetuses will not reach term. So counseling is very, very important in this situation. Apart from understanding the surgical morbidity and mortality postnatally. This structural heart disease is seen with a complete heart block, postnatal cases up to half. Up to half of fetal cases and 1/3 of postnatal cases it is seen. Now, this is related to a structural heart disease, and if we do not have a structural heart disease, the prognosis of complete heart block is very, very different. That too, if it is in isolation, without maternal antibodies, the prognosis is much better, though your management is going to be different. This is a situation where we cannot think in terms of using medications like steroids, etc. And the third, as we understood, is with maternal antibodies. Now, with maternal antibodies, usually what happens is, as soon as the mother gets picked up, most of the situation, it's the other way. When the fetus is picked up to have a complete heart block, the mother gets evaluated. Unfortunately, the mother having positive antibodies, and then they come is after starting treatment, before conception, after conception, and then asking for a fetal echo situations are much less common. Now, with the awareness, I think if one child has a heart block, usually the family gets counseled extensively during the second pregnancy, and then a systematic approach is usually followed. Antibodies, then the workup of the maternal antibodies is done, and the most damaging antibodies are the antibodies which are written here. They are usually ROLA antibodies, and the risk of fetal heart block if the mother has antibodies is up to 3%. So it's not a significant risk if it's a primary mother and if the mother is antibody positive. And actually now we have a protocol of starting HCQ, which we will see in the last slide today. Then the risk could be reduced further. but in general, the risk is 3%. But if one baby is already having a complete heart block and the mother is antibody positive, the risk increases to up to 20%. Second important thing is if the mother is antibody positive, don't keep focusing only on development of heart block. Remember that your impact can be much beyond the AV node. For example, it can affect the sinus node, it can affect the bundle branch, it can affect the myocardium, it can affect the chordae, etc. So you can have sinus node dysfunction, you can have myocarditis, you can have cardiomyopathy, you can have ventricular dysfunction, etc. So whenever this picture comes in front of you, always remember to see the baby as a whole and do not only keep focusing on the rhythm assessment. Now, so exactly what happens is this understanding that initially, to start with, initially the fetus has a normal conduction, and at 12 weeks you have ROLA antibodies which cross the placenta and they bind with the specific cells in the baby's heart. They cause inflammation, scarring, and fibrosis, and that's where you have the development of congenital lupus. There is some role of maturation of the fetal immune system in this whole process. So here we can understand that at what stage we pick up. Is it picked up after fibrosis happens, then the development of heart block is permanent, versus if it is in the inflammatory phase, then it could be a reversible stage. And complete heart block is usually unlikely before 18 weeks and after 28 weeks. So this is what we were understanding. I think starting from 16 weeks to 30 weeks would be the period where you need to completely monitor. Also remember that not all fetuses can be picked up in the early phase. There are lots of instances where directly you will see them in an established heart block, even on regular follow-ups. So even if you regularly follow them up, it doesn't ensure you 100% pickup in a stage where you would want to pick up. So this counseling is important of the family, but for you to understand, after 28 to 30 weeks, it's unlikely to have a development of heart block. And all of you know that there are 3 grades of heart block. This is just to run through it. The first degree where you have a prolonged AV interval, which for us is going to work as PR interval. And in general, this is important that the AV interval increases with gestation and decreases with increasing heart rate. With the heart rate increasing, we know it is going to decrease. It's very logical. But with gestation, it increases. And hence, whenever you want to check your PR interval z-scores or range, remember that you have charts available and compare your PR interval with that gestational age. In this situation, your atrial rate and ventricular rate is obviously going to be the same. If it's a second degree AV block, you have slow prolongation of PR interval till a beat is dropped. Or you have, for example, a 2:1 conduction. And as we understood, the most important differential is going to be a blocked atrial ectopics in terms of atrial bigeminy, which is blocked. And both the situations, your atrial rate is going to be more than the ventricular rate. And if it's a third degree, it's a complete dissociation. Ventricular rates are usually less than 60. If my ventricular rate is around 70, 80, then I'll think in terms of a second degree AV block rather than a third degree AV block. And here again, my atrial rate is going to be more than the ventricular rate. So this is how you would differentiate the first degree, second degree, and third degree, where here I want to pick up my PR interval to pick it up. My prolongation of PR would help me diagnosing first degree. My atrial rate being more than the ventricular rate at the end, or my PR interval changing is going to be the crux to diagnose a second degree. Whereas in general, my atrial rate much higher than the ventricular rate and ventricular rate less than 60 or 50 is going to be pointing towards third degree AV block. Now, this is the chart which I was talking about, where you have gestational age given and gestational age compared to the method, which can give you a PR interval. For example, here you have mitral inflow-outflow method, and you can see here that SVC aorta method is going to be different PR interval measurements compared to LV inflow-outflow. So your method is important and your gestational age is important. Now, in general, if you see, usually your monitoring will start in this phase where approximately this is going to be the range of your PR interval. And anything which is exceeding this is going to be a little worrying for you. So usually a cutoff of, I would say, 110 is acceptable, 110 to 120, but not exceeding 120. Also, remember that along with PR interval, try to see for the echo density of the atria and AV valve regurgitation. So this is what they are indirect markers of myocardial involvement. Try to see for the ventricular myocardium, atrial myocardium, and AV valve regurgitation. Some will develop prolonged PR before they develop complete heart block, but some will probably directly develop complete heart block. So the question comes, how frequently should I monitor when I want to monitor my PR interval? The whole idea of monitoring the PR interval is I want to pick them up early. As I said, we want to pick them up in the inflammatory phase and not in the fibrotic phase where complete heart block is established. Usually when I have a complete heart block set in, approximately by 20 weeks, I know the damage is irreversible. But it's unfortunate that sometimes even on weekly follow-up, I may not pick up prolonged PR and see CHB suddenly developing. So here you can see the first video is a 2D, and here you can see that it's very obvious. The atrial appendage is contracting much more compared to the ventricle, and the rates are obviously very, very slow. Subjectively, you can pick it up that this is definitely a pathological bradycardia. Try to see for AV valve regurgitation, the tricuspid and the mitral, you have biventricular regurgitation. This could be related to your myocardial involvement in terms of inflammation, or it could be a reflection of cardiomegaly, AV valve regurgitation, and development of hydrops. Now, this is just one example of a ductus venosus Doppler. You can see here beautifully, these are the S and the D and the A waves, and the A waves are abnormal. Obviously, they are so prominent, but remember that in complete heart block, we cannot take this as a reflection of hydrops or cardiac failure because the atria is contracting against a closed AV valve. So here this is the same, this is an IVC Doppler. What you see above the baseline are A waves and below the baseline is the S and the D wave. And obviously brady, so the rates are very low, and the atrial, the reversal is seen here. But again, remember that we cannot consider this direct evidence of hydrops. Now, apart from this, this is how you would take a mode cut. So you can see here, the one which is above is my ventricle, and this is the atria. And I'm trying to take the atrial appendage so that I have movements of the atria which are beautifully seen. So this is A, which is regular, and these are ventricular beats. The ventricular rate is obviously less than 50. And then you can see that absolutely no coordination. I don't have a 2:1 sort of a picture. It's really haphazard. So this is complete heart block. And if I try to Doppler, my Doppler pattern will look like this. Sometimes I feel in a complete heart block, M mode is much easier to understand compared to the Doppler. Here the ventricular beats are quite regular and significantly bradycardic, but the atrial events might be a little confusing sometimes. This is again a mitral inflow outflow Doppler. Look for abnormal myocardium. So this is what you will see, very speckled myocardium. You can see here the Cordy, the AV valve apparatus, and the ventricular myocardium has a lot of speckles here. And this is what should point towards a myocardial involvement. Counseling is very important. As your pregnancy will proceed, just not the brady, but also the myocardial involvement can give rise to a cardiomyopathy-like picture, which could make a difference in your timing of delivery, the final outcome in the child. And also look for signs of cardiac failure. If all of you would remember, last time also we went through the cardiovascular profile score, which is important. So what you would look into that is everything starting from cardiac size, AV valve regurgitation, ductus venosus Doppler, umbilical artery, umbilical vein Doppler, etc. So let us run through this because this is important. Any presence of effusions, so pleural effusion, pericardial effusion, and ascites, these three things are not difficult to see for us. Cardiomegaly, normally it should be 0.35 to 0.5, and heart size, you can measure it based on the the diameter ratio or the circumference ratio, whichever you are comfortable. Anything which is more than 0.5 is not normal. Cardiac function in terms of AV valve. So if there is a presence of tricuspid regurgitation or mitral regurgitation, try to Doppler and see if it is holosystolic. And your diastolic filling is important. You need to have a separate E and a A wave. If I have merging of E and A wave, that could point towards the score 0 in the cardiovascular profile score. The umbilical artery Doppler, remember that you have umbilical artery to be Dopplered at the fetus end and at the placental end. And normally you have umbilical artery Dopplers which are pulsatile. So it's a positive flow, and the diastole also should have some amount of continuation of a positive flow. If this flow in diastole disappears, or if there is a reverse, that's not correct. And venous Dopplers, you would include umbilical vein and ductus venosus. Umbilical vein along with the umbilical artery, you will Doppler it in the umbilical cord. And normally umbilical vein is like a slow continuous venous flow without any pulsations. If I have pulsations, they are considered actually to be ominous. And ductus venosus Doppler, as we saw, you have a SD wave. But if I have a decreased velocity in atrial contraction, that means I have a negative wave, then that means it's not okay. Again, in a heart block, you have to put the whole picture together and not just take the ductus venosus Doppler in isolation. And normal scoring system should be 10. So 10 is a normal score. The more I move towards lesser score, I know the child is developing hydrops. And what do I do? So in general, the prognosis, there are certain prognosticating factors in heart block which we need to understand. So presence of a congenital heart disease, as I told you, if there is a structural heart disease, the prognosis is not good. Now, ventricular rate is important, and any rate which is less than 55. Remember that your interventional indications even after delivery also takes care of this ventricular rate. So if my ventricular rate is less than 55, there are two guidelines. One says less than 50, one says less than 55 as an indication for putting a pacemaker in the neonatal period. So ventricular rate is important, but surprisingly, even atrial rate is important. So atrial rate less than 120 is also not correct. Presence of congestive cardiac failure based on your CVP score, and presence of endocardial fibroelastosis. If you see those hyperreflectile structures, presence of AV valve regurgitation, etc., then that could be a negative prognosticating factor. So in complete heart block, if you have, for example, ventricular dilatation or you have ventricular dysfunction, is it related to bradycardia itself or is it related to myocardial involvement? It's sometimes difficult to predict. Sometimes presence of EFE could differentiate these two things. And your prognosis also in terms of response to putting a pacemaker is also going to be different. If it's just related to brady, the response to putting a pacemaker is going to be satisfactory. But if it's going to be related to abnormal myocardium, just putting a pacemaker may not completely normalize everything for the child and also a long-term future. Now, with this, I'm just going to summarize a flow chart for brady. So if you have a heart rate which is less than 110, you understand that it is fetal brady. Then you go for your VV interval. If my VV interval is regular or my VV interval is irregular. If my VV interval is regular, then you look for your AV relationship. And if my AV relationship is regular, then it's brady sinus or low atrial. Whereas if my atrial rate is more than ventricular rate, then it could be either an AV block or blocked atrial ectopics. And in an AV block, I have a regular AA, whereas if it's blocked atrial, it's irregular AA. So at the end of it, check your VV interval, check your AA interval, and check your AV relationship. I personally feel compared to fetal tachy, fetal brady is actually much easier to understand and sort it out. And your management is also a little more simpler, though the response to treatment is not as easy as in tachy. So what do I do once I understand that it is sinus brady? I have decided if it's sinus brady, I'm just going to observe them once in 4 weeks, tell the mother to check for fetal cardiac movements, and after I have evaluated all the secondary causes for sinus brady. If it's a blocked atrial ectopic, again monitoring once in 4 weeks with intermittent monitoring of the gynecologist. Avoid caffeine containing items for the mother, and explain the mother to be careful watching the fetal movements. Now, if it is an AV block, then what do I do? So if it is an AV block, then there is some role of steroids at certain point in time. And what is that? Now, if it is going to be a first degree or a second degree AV block, I understand that there are chances of reverting it to sinus rhythm. But if it's a complete heart block, it's unlikely generally after 20 weeks for my heart block to revert to sinus rhythm. So whenever I'm trying to think in terms of use of steroids in that situation, I have to be a little more clearer, because there are side effects. Side effects in terms of growth of the baby, oligohydramnios, maternal blood pressure and blood sugar levels and fluid retention, etc. So in general, if it's a second degree AV block, I would try using dexamethasone, and the dose is usually 4 milligram once in a day or twice in a day till I have a sort of reversal. And once I revert back, I can make it once in a day till delivery and then evaluate postnatally. Fluorinated steroids, in terms of complete heart block, I could consider using it when I have ventricular dysfunction. And in terms of inflammation, it could probably help. As we spoke, myocardial inflammation to some extent could be controlled, and further damage could be prevented with steroids. There are a few case reports where people have used immunoglobulins along with steroids in that situation. The role of beta stimulant sympathomimetics like salbutamol and terbutaline is in terms of improving the rates by few numbers. So if the heart rate is less than 55, with any etiology, I could consider this in terms of reducing the possibility of developing cardiac failure because of bradycardia. Steroids again should be considered only if there is proof that the mother is antibody positive. In terms of isolated cases or presence of structural heart disease, we would not use that. So I'm just going to have a little 2-3 slides of a recap of the last session and today's session. This is just sort of a summary of fetal arrhythmia, where if you have an atrial rate which is irregular, what would you think? This could be atrial flutter with changing rates. It could be atrial ectopics. If it is a fast atrial rate, then it's a flutter or any type of SVT. And if it's a slow atrial rate, then it's a brady, or it could be ventricular tachy where the atrial beats are hidden. The ventricular rate, if it's irregular, it could be a second degree heart block. It could be an atrial ectopic which is not conducted. It could be ventricular ectopics or atrial flutter with varied ventricular rate. If it's a fast ventricular rate, then again all causes of SVT or VT. And if it's a slow ventricular rate, it is either a blocked atrial bigeminy or a heart block. The most important would be the AV connection, where if atrial and ventricular rates are the same with tachy, then it's SVT or ectopic atrial tachycardia. If atrial rate is more than the ventricular rate, then heart block, flutter, or ectopics which are blocked. And if atrial rate is less than ventricular, then it's ventricular tachy or nodal tachy, both of which are very difficult to differentiate in fetal life. So I think we will end our session today. If anybody has any questions, you can put your questions in the chat box, please. Any questions? Anybody has any questions? Okay, then thank you so much. Have a good day.